Hi, welcome to Tip of the Week. I'm Frank Brady. Today, in a marked departure from our last few issues, we're beginning an exciting new series entitled Find a Need and Fill It. The series will focus upon a large, growing, and largely underserved market for primary care. This series will probably generate cognitive discomfort and controversy for some viewers. Long-cherished ideas die hard, and some content may be a bit jarring to some very good people. It's not our intent to upset anyone, and my apologies if we do. But sometimes it becomes necessary to tell people things they don't want to hear. I hope you'll bear with us until the end. I think you'll find it worthwhile. Thank you very much for watching. We're going to begin with a bit of relevant history. Many viewers will already know this, but some may not. In order to understand why things are the way they are, it's important to understand that for most of the country's history, and well within the memory of many people alive today, the patient care environment was very different than it is now. The term healthcare, that we now use every day without thinking, was coined in the 1940s after businesses began to offer hospital insurance as an employee benefit to get around wartime wage and price controls. Most Americans did not have hospital insurance until after World War II. Because many hospital people, especially those in the caring professions, are very patient-centered, they naturally want to believe that what we call the healthcare system is patient-centered as well. Unfortunately, it is not. Instead, the U.S. healthcare system is third-party payer, or insurance-centered. The Affordable Care Act was designed to sell hospital insurance and prolong the life of Medicare. So is its Republican-sponsored replacement. The problem with the term healthcare is that it conflates insurance cost with medical and hospital service cost, thereby confusing public understanding. That conflation effectively hides the fact that the insurance-based third-party payment system, that's Medicare, Medicaid, Blue Cross, and commercial insurers, is directly responsible for at least 40% of today's healthcare costs. You can see evidence of that confusion every day. When people complain that they are losing their healthcare, they are often talking about their healthcare insurance. Hospital insurance and medical care are not the same thing. Many people in the U.S. have insurance but are unable to obtain medical care in the office or hospital because they cannot pay their deductible, or because there's no physician or hospital in their area that accepts their policy. We began by suggesting that history was important to understand because it helped explain why things are the way they are. Trends are important, on the other hand, because they help us understand where things are going. Look at these numbers. Between 1960 and 2014, the portion of U.S. healthcare expenses paid by patients decreased from 48% to 11%. The portion paid by government increased from 24% to 49%. And the portion paid by private insurance increased from 21% to 33%. When interpreting these numbers, remember that almost no one had insurance until the 1940s, and Medicare and Medicaid did not exist until 1965. An important question to consider after digesting these numbers is what effect have these trends had on the total amount spent on healthcare in the United States? The third-party payment system is directly responsible for at least 40% of what are called healthcare costs for two main reasons. With respect to the total amount of healthcare costs, the graph shows the explosion in growth immediately following the introduction of Medicare and Medicaid in 1965. Part of this is really Econ 101. When potential consumers of any desirable service, including patient care, are shielded from the cost of the consumption decision, demand will increase exponentially. When you want more of something, you subsidize it. When you want less of something, you tax it. This is another way of saying that the appetite for free money is virtually insatiable. This graph shows the total amount of spending. The third-party payer system also drives up unit costs, the cost of an exam or a patient day, because of the mandates it places on hospitals and physicians as conditions of participation. It would be comforting if we could say that the expenses resulted in longer, healthy lives than would have been the case had the money not been spent. Consider these numbers, which include averages for males and females together. A 65-year-old American in 1960 could expect to reach 79.4. In 2014, that American could expect to live to 84.3. That sounds impressive until you learn that in the 54 years since 1960, life expectancy for a 65-year-old American in 2014 increased only 4.9 years, whereas in the 54 years between 1906 and 1960, life expectancy for a 65-year-old American increased by more than 18 years. The growth rate has actually declined. Among the more difficult concepts for hospital people from the caring professions to come to grips with is the idea that there is a great deal of elasticity in the demand for primary care. Patient care people are accustomed to thinking of medical care in terms of need, not in terms of a consumer demand for service. The very idea that the number of patients who present for care could be affected by personal financial considerations, even for primary care, is often repugnant to them. In our example, 71% of emergency department visits are unnecessary, or could have been avoided, according to the Truven study. This doesn't mean that people who show up in the ER should be turned away. It does mean that there is an observable correlation between primary care service volume and its direct cost to patients. The immense strategic operational importance of this trend to hospitals and physicians who provide primary care cannot be overstated, and it must not be ignored. Outpatient activity produced approximately 12% of hospital patient revenue in the 1990s. Today, outpatient activity accounts for about 60% of hospital patient revenue nationally. Outpatient revenue is now generating more than 85% of patient revenue in some of our client hospitals. This raises two existentially important questions. First, what is the trajectory of these trends? Second, how much of this outpatient activity can be performed outside of the hospital? This concludes today's tip of the week. In subsequent tips, we will explore the impact of the third-party payer system on patients, local communities, and the public at large, its effect on hospitals, individual physicians, and the private practice of medicine, and begin to explore solutions. We hope you found this information to be of interest and useful. Thank you for watching, and have a great day.